Hello again, friends. We are going to discuss Noonan syndrome here. And Noonan syndrome is pretty common, and so I would expect it to come up on the test. It does share some features in common with Turner syndrome, and so you want to be aware of what some of the differences between Noonan's and Turner's are, so that it doesn't trip you up on the test, because they may try to conflate the two of them together and try to make things difficult for you. And in practice, it's going to be can be somewhat difficult to tell the two apart if you're not paying real close attention. We should always pay attention. So we're going to do an overview. We'll talk about the genetics as usual. We'll talk about the features, give you some pictures. We'll discuss the differences between Noonan's and Turner's, some things that are very similar, which are most of the things, and then some of the things that are different between the two of them that you'll want to be aware of. We'll talk about development for these children. As they become adults, they do have a normal life expectancy most of the time. We'll talk about how you make this diagnosis. It's a little bit different than most of the time how we diagnose genetic disorders. And then we'll talk about management and some considerations for the long term. So Noonan syndrome is a common autosomal dominant disorder that can involve any one of a number of genes involved in cellular signaling pathways, typically the RAS-MAPK pathway, mitogen activated protein K, I believe. Protein kinase. Yeah. So anyhow, this can be found in a number of genes. So we don't necessarily know. A patient has Noonan syndrome. We don't necessarily know which gene is affected, and so there are a list of genes that we do know are implicated in Noonan syndrome. But in a minority of patients, they may have Noonan syndrome, but all of those tests are negative, and so that's something that you have to keep in mind and consider. Often, Noonan syndrome, as mentioned, is described as similar to Turner syndrome. As a matter of fact, in one resource I read, I saw Noonan syndrome described as Turner's-like syndrome, and it is similar, but I wouldn't call it that because there are some critical differences, and the most obvious difference is that Noonan syndrome can affect both, as you see here, both males and females, whereas Turner syndrome only affects females. So the mutations are to genes involved in the RAS-MAPK pathway, and these mutations are most commonly due to the PTPN11 or just PT11 gene, and so that's 50%, and that's going to be the most common. And if you're going to do any kind of genetic testing to test a patient for Noonan syndrome, you should start with this one because it's the most common. SOS1, RAF1, and CRAS can also be implicated, but PTPN11 is the most common. And then this leaves 22 to 32% of Noonan's cases that are on genes that are not discovered. So all of these are going to be negative, but the patient still presumptively has Noonan syndrome. Either it runs in their family or it's a sporadic case. And that leads us to this. Actually, 80% of Noonan syndrome cases are sporadic. So you have parents, they have no known history in either of their families of Noonan syndrome, but the child still gets it. And that's very common, and that happens, and it's actually going to be 4 out of 5 cases are going to be sporadic. 20% are familial, and so when it is inherited, it's inherited as an autosomal dominant syndrome. And so that means that these 20% are going to be a child who typically it's their mother that has Noonan syndrome. And so those are a little bit easier to diagnose, and typically you don't need to get labs for that because generally the mother's already been worked up. So the features, there are a lot of them. So you'll probably see some parallels to Turner syndrome. Big one is the short stature. Hypotonia can also be present. That can delay some of those motor milestones. Some of these children have some feeding difficulties. Usually it's not severe enough to lead to caloric deficiency, failure to thrive, but it can be, and so that's something to keep an eye on. They also can have cognitive delay too, but this isn't as severe as what you'd see in some other genetic syndromes like Down syndrome or Fragile X syndrome, where the cognitive delay is much more severe. Typically, with Noonan syndrome, the average is just below normal. I think the average IQ is like 85 or 86. So it's not significantly. It is significant, but not severely less than average. The facial features. This is going to be a big one. This is what's really going to help you with diagnosis. So hypertelorism. That's one thing. Their eyes are set far apart. Another big thing is they have low set ears, and those ears, not only are they low set, but the helices, the edges of the ears, are thickened. They may also have ptosis, which is like a droopy eye. They can also have downward slanting palpebral fissures, so the eyes are they kind of look like sad puppy eyes, sort of. Low nasal bridge, micrognathia, and webbed neck. So a lot of times this gets described as an inverted triangle facial formation. I'll show you some pictures and kind of see what that means. Skeletally, they can have shield chest as well as pec excavatum, which is that indentation in the chest. They can also have scoliosis. Cardiovascularly, they tend to have right-sided heart lesions. The most common is pulmonic valve stenosis. They can also have septal defects, and some patients can have hypertrophic cardiomyopathy, either the non-obstructing or obstructive version. Reproductive system, mostly the problems are going to be in males with cryptorchidism, smaller penis, and the males tend to have reduced or absent fertility. With females, you'll see pubertal delay, just like you'll see in males, but the women tend to be they tend to be fertile. Other things that you can see are lymphedema, renal anomalies, bleeding disorders. They can have dryness of the skin, and then they can also have some issues with their eyes. They can have cross-eye, refractive errors. So this is just sort of re-illustrating all the things I just told you about. Oh, another one that I meant to bring up too is Arnold-Chiari malformation. So if you have a patient with diagnosed Noonan syndrome and they develop severe headaches or dizziness, you'll want to screen for Arnold-Chiari. So this is a illustration of a child with the typical Noonan's facies. So wispy hair, I didn't really bring that up because this is rather non-specific, but the wispy hair tends to be a little curlier too. That's something that you can see. This thickly hooded prominent eyes, they are downwardly turned. Palpebral fissures are downwardly turned. Then they can have this nose that sort of curves upwards, and then this they call a cupid bow appearance of the upper lip. So those are some other facial features, but also notably these low set ears. This is what you'd see more in an adult, and that having been said, what I want to also bring up is that the facial features in Noonan syndrome, they have a tendency to evolve. So the most prominent Noonan syndrome facial features are going to show up in the toddler. Whereas a little baby, you might not see it as much, and then in an older adult, you might not see it as much. So it's sort of that toddler period where you really notice these facies. Now this kid is a little bit older than a toddler, but you can see the lower positioned ears. They're sort of rotated posteriorly. You can see the very thick auricle, also the very pointed chin. And this kid's wearing glasses, so that probably means he has some refractory problems. You can see the downward pointing palpebral fissures, and then he also has a very prominent forehead. And this is sort of that inverted triangle shape of the face. So this toddler, you can see sort of that nose that's curved up here. You see a little bit of drooping here in her right eye. Her hair's covering up her ears, so you can't really appreciate that. So here's a very characteristic Noonan's facies. Again, you have pointed chin, a little bit smaller. very, very male-rotated and low-set ears. You also see these sort of bags underneath the eyes. That's pretty common as well. And again, like I said, Noonan syndrome patients have a tendency towards curly hair, but not all of them. So this is the same child, and what this really just illustrates is how the facial features become very characteristic right around toddlerhood, early childhood. But as he grew up, his facial features sort of normalized. So it's as a baby he looked pretty normal, and as a young man he looks pretty normal. But when he was a toddler, he showed some pretty prominent facial features for Noonan syndrome. So here's an example of the chest. You see some widely spaced nipples here, especially this right nipple is sort of on almost on the side of the chest. And then you see this little indentation, and that's your pec excavatum. So here's an example of shield chest. This is something you can also see. You also here see the widely spread nipples. You see a little bit of neck webbing here. That's also something you can see in Noonan's, and then scoliosis. Lymphedema can be seen as well, and this can be seen anytime during infancy. It can be also seen during adulthood, adolescence, so that's something to keep an eye out for as well. Noonan syndrome patients have delayed growth, and they actually have their own growth charts that you can use, so that because if you're using a normal growth chart, you know, for normal children, you may think, oh, this is failure to thrive, but really it's not. It's a Noonan syndrome child probably growing like they should. And if you look, the 50th percentile for a Noonan syndrome child is actually at or below the 3rd percentile for a child in stature. So, all right. So Noonan's versus Turner's. So obviously, the two places where this differs is the error. So remember, Noonan syndrome, it's a mutation of these particular genes or on autosomal chromosomes, such as PTP-N11 or SOS1. There's some other ones too. And Noonan syndrome can be inherited, and it is in 20% of the times. Turner syndrome is a aneuploidy. It's 45X, and this is never inherited. This is always sporadic. Noonan syndrome affects males and females, whereas Turner syndrome affects females only. So what do they have in common? Everything I put here in blue are things that they have in common. And I didn't include absolutely everything that you can see in Noonan's and Turner syndrome, so this isn't completely comprehensive. But in both Noonan syndrome and Turner syndrome, you're going to see neck webbing, you can see low posterior hairline, you can also see low set ears. You can also see the shield chest and wide nipples. Both can have scoliosis, and they do tend to have short stature. They can also have cubitus valgus, which is sort of a abnormal positioning of the elbow. As far as development, they both tend to suffer from learning difficulties. They both tend to have pubertal delay, and they both have lymphedema. Now, on the other hand, with Noonan syndrome, you see more of those facies, those widely separated eyes. They're downwardly slanted. They may have ptosis. They tend to have that really pointy jaw, and the ears are generally more abnormally pronounced in Noonan syndrome. Also, in Noonan syndrome, there's a tendency to have pec excavatum. That's not typically seen in Turner syndrome. The big one is with the cardiac abnormalities. So both Noonan's and Turner syndrome have a tendency towards congenital heart defects, but the difference is where they're at. So with Turner syndrome, they tend to be left-sided heart lesions. So coarctation of the aorta, for instance, or a bicuspid aortic valve. With Noonan syndrome, it tends to be right-sided lesions. So particularly pulmonic valve stenosis. Then you can also get hypertrophic cardiomyopathy as well. Then these other issues with Noonan syndrome, there's a tendency towards bleeding disorders as well as skin issues, dry skin. With Turner syndrome, you see more of these autoimmune issues like type 1 diabetes, Hashimoto's thyroiditis, as well as other autoimmune disorders. So lots of similarities, but some prominent differences, and you should remember those differences, particularly these cardiac differences. So what about their development? So they can have hypotonia early on, and that hypotonia can delay gross motor milestones. And so if you already know the child has Noonan syndrome early on, you can go ahead and set these children up with physical therapy, and that can help them achieve some of their milestones and strengthen themselves. Cognitively, difficulties in school can manifest at various times, really depending on how badly they're affected. So if they're more affected, it's probably going to manifest earlier than if they're less affected. The range is variable. So you can see a very wide range here. 53 to 127 is the reported range. 127 is quite a high IQ. That would be consistent with somebody that can go on to grad school and beyond. But the average IQ is about 86, and certainly an IQ of 86 is not really going to impair your functioning too much. Social development can be impacted by delayed puberty. So note that the mean onset for puberty is 13 to 14 years of age for girls. That's about 3 years later than where it normally comes on. But it's about 13.5 to 14.5 for boys. So the pubertal delay is much more significant for girls than it is for boys. Remember that girls tend to hit puberty about a year or two younger than boys. And you can see with Noonan syndrome, they're roughly about the same age, 13, 14 years of age for onset of puberty. If there is no development of thelarchy, which is the beginning of breast development by age 13 in girls, or if there's no testicular enlargement from Tanner stage 1 by age 14 in boys, then you should refer these patients to a pediatric endocrinologist for estrogen or testosterone therapy based on their sex. For diagnosis, typically Noonan syndrome is suspected clinically based on a family history. Remember, 20% are going to be heritable. But in the majority of cases where it's sporadic, you're probably going to need to do genetic testing. And so you'll do DNA testing, looking for the exact gene that's implicated. Remember that we've got about 4 genes that we are aware of that are implicated with Noonan syndrome. You'll start with the more common one and then work your way down. So start with the PTPN11 and then you can work your way from there. As far as management, there are a lot of things you're going to want to do on initial diagnosis. So first thing you want to do is get a cardiologic evaluation. This is going to consist of EKG and echocardiography, but you'll want to have the pediatric cardiologist do this because some of these problems can be really severe and you want to make sure that they're diagnosed. But this is going to consist of an EKG, mostly looking for the hypertrophy of the heart, and then echocardiogram to look for any congenital heart diseases. You'll want to consult pediatric ophthalmology for evaluation because there is such a high incidence of strabismus and refractive disorders. Audiometric evaluation is timely. Even though most Noonan syndrome patients don't have difficulty with hearing, you still want to get that done. As far as the labs that you want to get, mostly this is going to be looking for bleeding issues. So you want to get a CBC. There is a pretty good incidence of thrombocytopenia in Noonan syndrome patients, up to about 50%. You'll also want to get a coagulation panel and then factor 11 levels. And factor 11 is the most common cause of bleeding disorder in Noonan syndrome patients. Ultimately, though, these labs by themselves, this is not a comprehensive hematologic workup. And all Noonan's patients should have a full hematologic workup by a hematologist before they have any significant surgery. And so that can be done, but you don't necessarily need to do it right away. You also want to get a renal sonogram because there are renal abnormalities that are associated with Noonan's, and then just a developmental assessment to see where this child is at as far as their physical development, as far as their cognitive development. And if necessary, you can send them to a developmental pediatrician. If there is short stature, you can send them off to a pediatric endocrinologist for growth hormone therapy, and it really just depends on the wishes of the patient and of the parent, usually the parent because these are young kids. But a lot of patients with Noonan syndrome do achieve relatively low end of normal height, even without growth hormone therapy. So it really is, it's not necessary. You don't have to give growth hormone, but it will help them grow a little bit taller than they would otherwise grow if they didn't have it. Usually about 3 or 4 inches. It's not going to be dramatic, but they will grow a little taller if you give them growth hormone. And then the other time you're going to want to refer them off to endocrinology is if there's significantly delayed puberty. So long-term considerations, genetic counseling should be advised in all patients, particularly when these patients get a little older and they're considering pregnancy. Remember that if a woman has Noonan syndrome, her risk of giving that disease to her child is going to be about 50%. It will be 50%. Neurologic symptoms such as severe prolonged headache, dizziness, balance issues, all of those things should raise a flag for Arnold-Chiari-1 malformation, and so you should get an MRI to assess for that. And long term, they are at risk for hematologic cancers. That includes ALL and chronic myelomonocytic leukemia. And with that, I don't think I had anything else to talk about. So go ahead and write me any questions if you have them. But otherwise, I will see you next time.